Non-metastatic CRPC is being evaluated in with a number of different therapies right now. Apalutamide, orally available AR antagonist. Darolutamide is another orally available AR antagonist. Abiraterone has been studied in this setting in phase 2 studies, and enzalutamide has been studied in this setting as well. So those are the androgen receptor hormonal therapies that are being evaluated. There are a number of other smaller studies looking at different concepts, immunotherapies, and things like that in this setting, but none of them are quite to the mainstream clinic yet. The monitoring of patients with castration-resistant prostate cancer is undergoing a bit of an evolution because we're seeing new generation imaging modalities come to the clinic. So more specifically, we are very excited about things like the lutetium gallium-68, I'm sorry, not the lutetium, the gallium-68 PSMA targeted peptides, which help us to sort of lead to targeted imaging of prostate cancer. There are other approaches, fluciclovine and others like that are available in many clinics around the country. And so this is part of the process of evaluating non-metastatic castration-resistant prostate cancer. Non-metastatic castration-resistant prostate cancer exists to some degree because of the failing of our old imaging modalities, right? And so the bone scans that we've used for decades are relatively weak, and so, but they're still used. CAT scans are still used. And I would actually add that one of the things I've noticed is that patients in a variety of clinic settings, they may have pelvic imaging done, they may have bone imaging done, but actually many patients harbor lung metastases. And so the imaging of a patient who's felt to have non-metastatic disease should also include a lung CT, at least once, at least at baseline. I'm not sure it's important exactly what the training discipline is of the physician treating the patient, as long as they understand what they're doing and they have experience doing it. In my clinical practice, I give all the hormonal therapy. I don't really have any competition from urologists in terms of treating CRPC because in my community, that's not what they do. The urologists who are well educated on the side effects of therapy, on how to monitor patients, on what's available as a therapy for patients. In other words, anybody who's treating a patient needs to know what the alternate treatments are available and what they're going to do if this patient's treatment fails. I think that any clinician who's treating castration-resistant prostate cancer now needs to understand the genomic revolution that we're undergoing, and they need to know what the genomic findings, if they obtain them from a patient, mean, or the fact that they need to think about obtaining genomic findings from their patients because it will alter therapy in the future. And so whether that patient's an oncologist or a urologist, I don't really care. What's important is the level of experience, the level of knowledge, and I'd also say the level of curiosity about the disease, because this is a fascinating, nuanced, complex disease. And we aren't going to discover even new personal ways to treat it or new ways to research it if we're not asking questions and integrating new therapies and modalities into our clinical practice. Patients with castration-resistant prostate cancer are enjoying the best survival they ever have. They have a number of treatment options available to them. And what we are seeing now is, in addition to seeing new therapies enter the clinic, we're seeing the established therapies demonstrate benefits earlier and earlier in the clinical course, which is going to allow us to give therapies in the context of patients who aren't quite as ill and don't have quite a high degree of tumor morbidity. And so I think what this will translate into over time is a prolongation of the time in which patients are experiencing a preserved quality of life, they're preventing complications, and they're going to live longer. And it's very gratifying to be part of that movement.